Welcome back to the Movement Professional Podcast. I'm joined again by Dr. Frank Mallon. Frank was here a couple of weeks ago, and we talked about Postural Restoration Institute and just the integration of posture throughout the body and how that can help. And we got some good feedback from that discussion. And one of the things I thought would be useful is because I know Frank can go real deep into some of this stuff, and I think it's really necessary to get a little bit deeper discussion on different body parts and how they can connect the whole. So today we're going to touch on dentation, airway, jaw, things that integrate with common musculoskeletal things that you might go see a physical therapist for, but you might not necessarily typically connect the dots to some of these areas. And that's something that Frank specializes in. So I'm going to sort of be a bystander. I'm sure I'm going to learn a lot from this conversation. I'll chime in with my experience, but we certainly have slightly different ways that we run a clinic. So I want to get Frank's the expert here, and then I'll chime in. But Frank, if you want to reintroduce yourself, but also maybe give a general overview on how you use some of these things with dentation, whether it be airway, TMJ, and connect it to some common musculoskeletal pains that typically aren't treated that way.
Sure, Chris. Yeah, thanks for having me. It's good to be back. I was introduced to some of these concepts earlier in my career as I started to take a deeper dive into, the whole holistic PT thing and kind of looking at the whole body. And I had no idea that teeth mattered aside from chewing food at the time. Right. And, it was really eye-opening to me early on how important teeth are for our whole nervous system and how they can really help. They do a lot of things aside from just help us chew food. The sensory component of the periodontal ligaments and something like 5,000 nerve endings per square millimeter in the periodontal ligaments are hugely important for how our brain knows about where things are in space and how it even can appreciate where both sides of the body are and where it's going to put our mandible. And that mandible really communicates significantly with the midbrain and the pons and our brainstem as far as helping us understand where center is. If we have teeth that come together in a way that is maybe not neurologically ideal, then it can start to skew how our body is going to orient itself to find some stability. And that can cause certain cranial torsional patterns, or it can lock us into certain cranial torsional patterns, or cranial torsional patterns for other reasons can cause our teeth to touch in a less than ideal way. So when I got introduced to these concepts, it was really my experience as a patient that allowed me to really appreciate the value of how they can really help with helping regulate somebody's autonomic nervous system, which is their unconscious nervous system, the balance between that sympathetic fight or flight versus the parasympathetic. And our occlusal plane of our teeth corresponds often, most times, with our C2 cervical segment.
Okay.
And that sets a good floor for all the stuff above it, our upper cervical spine, as far as C1, but also mainly our OA joint, which is the union of our occiput and our atlas. And really, the key to all of this is our brainstem runs right through that area, right? So right where our occiput and our top of our cervical spine meet, in the base of our skull, around that foramen magnum, our brainstem, which regulates a lot of our body's autonomic nervous system, is positioned there. So if there is some torsion in this upper cervical spine, and these teeth are hitting well in a way, or familiarly in a way that's kind of holding you in there, it can cause autonomic dysfunction. It can cause often, a lot of times, persistent head or neck pain. migraines. We see a lot of this tends to be off with people that have more complex chronic conditions, such as fibromyalgia type conditions, the POTS type conditions. But it doesn't have to necessarily be those things. There's often times where somebody has persistent hip or knee pain, and it's because of how their whole cranial system from the top is kind of oriented. And when we look at everything as a whole, when we talk about the regions of our body, we have a sacrum down in our pelvis with two pelvic bones on either side of it. We have sternum in our chest with a rib cage on either side of it. But in our head, we also have a sphenoid bone with temporal bones on either side of it. And those three regions, sacrum, sternum, and sphenoid, are always kind of communicating with each other, or should. And if one goes a certain way, the other two oftentimes try to like balance it out to help keep you upright. So the power of how much this stuff up here influences all the stuff down there is huge. The ability to keep oscillating, alternating, reciprocal fluid motion through our pelvis, our rib cage, and our cranium really helps kind of regulate our autonomic system. And these temporal bones that are under our ears, the T in TMJ is temporal, and that's the temporal bone. Really, as I started to learn this, what I really gained a huge appreciation for is these temporal bones can move. And when they move, that can also influence how the jaw sits. So if I have certain areas of my neck that are working harder than the other, and they're maybe pulling on these temporal bones more on one side than the other, that can cause a temporal bone to get pulled into a position where it actually changes the position of that TMJ joint. And now the jaw may end up going a certain way, really, because it's just trying to stay in its base at the temporal bone. So when we see jaws that, tend to like to go one way and not so much the other, that starts to give us an indication that maybe these temporal bones could use some attention. But when I'm looking at somebody and deciding if this is a relevant piece, we always take a thorough history, but a lot of times things that jump out at me as potentially relevant for the patient would be if they've ever had teeth pulled. And fortunately, it's not happening as much anymore, but in the past, it had been common practice for people who were told they have small mouths that dentists would just take teeth out to say, oh, now things can fit well. But what fortunately is getting more and more understood is that those teeth have purpose, and those teeth, and really, if you were told that you had too much teeth for your mouth, really the problem was that you had not enough mouth for your teeth.
For sure, yeah.
So really now they're moving more towards expanding mouths. It is hugely helpful in helping optimize airways, because one of the huge problems was if you had a small mouth, there was probably a reason why, and it was probably an airway related type issue. And so taking out those teeth and then closing any remaining spaces with braces really just left you stuck with a really limited airway. And I often see people who have persistent and chronic, long-term standing and complex issues, and it comes back to maybe some teeth that got pulled when they were a kid. The main thing, or the proprioception that those teeth give your brain about where things are in space and how it helps shape and form the broadness of your face and that space, because that correlates with how well you're going to be able to maintain an airway, how well you're going to be able to breathe through your nose, which everyone now realizes is very important, and how, most importantly, your cranium, your skull, is going to be able to sit on the top of your cervical spine in an ideal way with optimal space preservation around that brainstem, and your brain's ability to really truly understand right and left well. And when we see people that have like cross bites where maybe the bottom teeth kind of wedge up into the top teeth, those cross bites become significant sources of reference and stability for somebody's system. But they're false senses of stability that's coming with compensations and towards the system. So they're great ways of helping lock up a neck and motion and add unnecessary tension and keep the body in a fight or flight response. The other thing that I tend to see a lot is oftentimes the way our teeth touch is really a reflection of where our head and neck is and how our cranial bones are aligned. And everyone's are a little bit different. There's a lot of different, cranial torsion type patterns out there. There's some that are certainly more common than others. But if you had braces and your body was in a little bit of a twisted state, whether it be in your spine or even in your head and neck or your shoulders, and they perfected your teeth so that cosmetically they look great when you smile, but now those teeth hit really well together, albeit with your head a little twisted or your C1 or C2 a little bit off and rotated. That can be troublesome for some people because those teeth will lock you into that state or that position. So a lot of times when people who maybe go to a chiropractor every week or every couple of weeks and they go, yeah, I'm always out in this, and this, no matter what I do, blah, blah, blah. It could be because the way that their teeth touch optimally, when those teeth come together, it's coming with some head and neck twist and torsion, and it's kind of locking them into that.
Right.
Part of getting to understand if someone would be a candidate for the kind of work I do with the dentist would be saying, okay, well, if we try to get your teeth to touch differently, or if we put your jaw in a different place, and there's certain ways we would do that, and does that change what you feel in your body, or your head or neck, or maybe even in this area that you're having persistent problems with? And that usually can tend to give us some pretty good clues as to, yeah, maybe we got to take you out of your bite with maybe getting you a splint that would kind of help us realign and repattern your body and get your body to find and feel different muscles that we would then use within our program, in the same way that we would put orthotics on somebody's feet to help level out their pelvis. Sometimes we're putting orthotics, quote unquote, in somebody's mouth to help their head and neck and really help influence the position of their cranium around their brainstem.
Let's say somebody's got a shoulder issue, and that's what their complaint is. But you're noticing in your assessment that there's some stuff going on up a bit higher. How are you putting it back into what the initial complaint is? Are you checking their shoulder range of motion? Are you assessing their function at the shoulder then after you do some of the interventions up higher?
Yeah, absolutely. If someone's coming with a shoulder issue, we're going to do all our usual shoulder tests that, as far as flexibility, range of motion, and even strength, that would help give us an indication of where their issues are. And if we suspect that there is some sort of an occlusal issue, meaning the way that their teeth touch, or we can get their jaw to go a certain way. And now this might sound crazy for people who haven't witnessed this or seen some of this, but sometimes we can dramatically change those tests just by changing some things in the way their teeth touch or the position of where their jaw is. And when that happens, it doesn't automatically mean somebody needs a splint. It may mean, let's start with what's available to us right now. So maybe I'll give them like a little over the counter temporary thing to just put into place to say, okay, well, and if they can see that their shoulder pain changes quickly and they can feel the muscles that maybe they had trouble feeling in the past just by their jaw being in that position, we say, okay, well, let's start here. Maybe take this thing, just wear it when you do your exercises, and let's see if we can get your body to kind of fall into place and learn this unconsciously. And sometimes we can, sometimes they need something a little bit more customized. If the dentition is relevant, we'll see pretty significant changes early on. And then that gives me more confidence if I'm going to ask them to commit to this process and trust me to meet up with me and a dentist where we're on site together and we're that. But we're always checking on is your shoulder feeling better?
Right.
That's what it's about. That's why we're doing it. And I'm grateful to have the relationships with some of the providers that I do at this point, who are willing to accept my feedback in what's happening throughout the body based on what we're doing in their mouth. People say, "Oh, I just want to go to that dentist you work with and get a splint." And it's like, well, you can't really just go to the dentist, because he's making decisions based on how to build this splint based on how your body's responding. So he's still a dentist, but it's really the nature of us being able to say, you know what, can you build up this splint a little bit more on this side or a little bit less on this side so they can feel these teeth but not these ones, to help us have come up with a splint for someone. And once someone, if they do get a splint, and that would look like kind of like a mouth guard, but it would be in their mouth, probably usually always on the bottom teeth to allow the tongue to stay on the roof of the mouth and to be able to slide around. And then when they get a splint, then that becomes like part of their program. And how much somebody wears it is always a little different for each person, but usually they're sleeping with it. Usually they're almost always wearing it when they would do any kind of exercises that I would give them. And certainly, or if they, even when they go work out and all this. And basically, like we said, it's just an orthotic for your cranial system here.
Yeah.
And when we do the splints, I'm always there when we take the impressions. Our teeth will touch slightly differently based on the position of our head and neck. When we make a splint for somebody, the goal of that splint is to recreate what a perfect neurologic bite would be for your system with your body in a neutral position. And so when I'm there on day one, when we take the impressions and the bite registration, I'm often holding that person's head and neck, their upper cervical spine and their cranial system, in a state where we are ensured that they're what in the PRI world we call neutral, but basically where the occiput and the atlas is all where we want it, that the cranial bones are in the proper amount of flexion, that we're in a good, what someone might think of as a craniosacral state or position, where things are pumping and optimally aligned. And once I get that on the table, because I bring my treatment table, I set it up at the dental office, and when we get that, and then when we're in there, then I'll tell the dentist, like, okay, now we're ready. And then he'll come in with the goo and he'll take the impression, say, okay, this is the Tony we want to take. We want to build the splinter, not the Tony that walked in here that was like twisted off, right? And then when it comes back from the lab, we meet up again, me, the patient, and the dentist. And from there, now we have some other work to do, because we've asked the lab to make it a certain way. But now we got to dial in and make sure that when that person moves that jaw around, that they feel the proper teeth at the proper time, that they're not hitting too much on one side and not enough on another. And we want to make sure that the splint is doing for their body what we're hoping and expecting for it to do. So there's a lot of fine tuning, because the subtle tiny amounts of different change on that splint make all the difference in the world for the body's sympathetic versus parasympathetic response. And of course, I'm always bringing it back to why they came to me in the first place. Right? We want to make sure that that shoulder is moving differently, that they can feel muscles activate maybe in new ways that they weren't able to, or that things aren't as impinged in the joint itself, just by the nature of balancing this neurologic tension through their system. But the proprioception in through this mouth is so huge. That's why if you ever get a sesame seed stuck in your teeth, it drives you nuts, right? and or hair or something, forget about it. And so the sensory piece of it is huge and incredibly powerful for our system. But I would never go on this journey with somebody or ask them to trust me with it if we didn't have a good amount of evidence and suspicion and confidence through our assessment that it was going to be the piece they needed to overcome this issue. I mean, and if it's an injury that just happened yesterday and they're in an acute phase of it, we're not going to jump to that. But if this is the kind of thing where they've been dealing with it for a while, no matter what they do, it's persisting, and they've seen a bunch of people for it and nothing's really helping, it's always an issue, then okay, we got to zoom out and say
Right.
what's
I think there's a lot to say there. And I think one thing I'll speak to is if you're not in the know about this type of work, it can seem a bit esoteric and it can seem almost unnecessary. But like as I started to learn about it, and once it sort of was illuminated to me, or like how it fit, it was almost like learning geography, where you only knew like your continent, and then all of a sudden you explored another continent, and now the map is bigger.
Mhm.
Right. And that's kind of how we learn anatomy in different specialties in healthcare, right? Like we learn the musculoskeletal, neuromuscular system, but even the way we learn neurological stuff is very much based on like peripheral nerves. We'll talk about like the worst case scenario if somebody gets like a spinal cord injury and how that works. And we're doing everything based on like kind of worst case scenario thinking that has a very obvious diagnosis, but nothing is described within a spectrum of pressure change. Right. And ultimately, that's what's happening all the time. And that's just physics 101, right? Like, as we have different pressures that are going on and changing within our body all the time. So things that we diagnose as, okay, I have a pinched nerve or I have some type of impingement on a nerve, that's just a compression. But a compression is just a change of pressure for a sustained amount of time that you're left with the symptom. Well, to appreciate that that's happening in a more dynamic fashion all the time, and what we're left with is responses. And so much of our responses as a human are unconscious. And we want them to be. Like, we don't want to be conscious of everything we do, or we would not be able to function. So the fact that so much is unconscious gives us that appreciation that there are all of this anatomical changes, like things that we learn about from a musculoskeletal standpoint are right next to things that a neurologist, someone who's really understanding arteries and veins, like it's all right there. And you're talking about like the brain and the brainstem, which is the ultimate part of the nervous system. But I just think it's not appreciated. It's almost like when you talk about that, you get laughed at by people who aren't in the know, because they're in like their own arrogance won't allow them to go there. But once you learn about it, it really is quite similar to just talking about a disc that might be impinging on a nerve root. Right? Like, what's the difference between, okay, there's a vessel that comes out of the foramen magnum of your skull, right? That can be encroached upon and then not encroached upon, and there's going to be pressure that changes. So, but it can be more so than you would want it to be, more so than would be optimal. And there are substantial changes that can happen to not just pain, but your overall affect. And that makes a lot of sense. So the way that we can look at like, what we're trying to do is we're trying to give people more room for that pressure to be able to do its thing. So like if the starting point is better, then maybe we don't have to do as much work somewhere else to try to make a change to it. But I think like on the other side of that, if you're not someone who is doing this specific work, there's still hope. It's just, it might be a harder process. Right. And I think that's like what we're talking about here is like, I love the idea of mindfulness, because I think some of the things with the sympathetic and parasympathetic nervous system, some of these responses that are going to happen naturally when we have an airway that's a little bit more closed down, we can actually get on top of some of that with mindfulness. And then what happens is that we start to know, like, yeah, I don't have an optimal airway. I don't have like optimal space there, but I have a mindfulness practice that for some people is really more work than you need to do if you also take care of the structure. But like together, the worlds come together, because you can never get anything quite perfect, right? There is no such thing in anatomy, but there is this idea of closer to optimal, closer to neutral. And that is opening up spaces so that we can breathe better, so that we're in a position that we don't feel as threatened just, lying down. So I think like this is the connecting of the dots there, which when it is thought of like that, whereas like this anatomy is always right next to each other. Learn something new, you have to appreciate that no matter what your specialty is, you're going to be affecting those major things, and that's going to have an effect on your nervous system. That's going to have an effect on your immune system, and that shouldn't be esoteric. That should be the norm. That should be natural, right? Like so I think it's only becomes esoteric because you learned it differently. Right. As soon as you learn something new, it opens up the doors to saying, oh, like I can't look at it another way now.
Yeah. Well, yeah, and that's kind of where I felt where, when I started applying some of these things, partly I had to because I saw how it helped me, and I was in a bad place in my own journey where I was kind of like, all right, I'll try it, and it
Right.
was like, amazing for me. So then I was like, okay, there's something to this, right?
Yeah.
And then as I started applying it to some of the patients who at the time I was maybe struggling with, and I was seeing some of these amazing changes, then that helped me say, okay, there's something to this. I gotta give this a chance. But Chris, you're absolutely right about the whole pressure system. And I would certainly agree that a lot of what people end up with in their diagnoses is their ICD-10 diagnoses is
Hmm.
really management of pressure, and they're the consequences of excessive impingements in some way. One of the things that was really eye-opening to me as I started to learn this, it was that, if we come back to those three regions, that sacrum with the pelvis, the sternum with the rib cage, and the sphenoid with the temporal bones, those areas all have some similar musculature layouts around them, and
Hmm.
there's some relationships in how maybe certain muscles in your hip are kind of aligned with, if we come back to the version of that sacrum and pelvis that's up in our cranium, there's some muscles that maybe move the jaw that are similarly laid out in the way that some of those femur moving muscles or some of those pelvic muscles are. So basically, sometimes when we see that certain things are stuck and we know that one area of is having trouble working, if we zoom out and we look at the version of that area that exists elsewhere in the body,
Hmm.
and we sometimes see that that's the bigger piece, and addressing that is what allows the
Yep.
problem area to kind of fall into place.
Yeah.
So oftentimes, someone will come and they're having back or hip issues and they really can't turn on a glute, and it's like, we can't get their glutes to work. They've done a trillion clamshells, and no matter what they do, they can't get them going. And so when we look at the version of the glutes that exists up in the cranium, up in here, and if that OA joint is a little hypermobile, and there's a lot of reasons why that could be, or if they can't activate maybe this posterior capitis, rectus major in the back of their head up here, maybe because of how their jaw is set, and we change something and they can then turn this on. Now all of a sudden they have a glute, which happens pretty
Yeah.
regular, and that's just one example. There's other things like that, whether we're talking about the pterygoid muscles and your
Well,
adductors.
I mentioned this in the last podcast, like when we had worked together, you just mentioned that there was like an iteration, a similarity between heel contact, which makes a lot of sense to me, like when I weight train, because like a lot of times if I'm doing a deadlift, I'm doing a heavy squat, like I want to feel my feet, and the heavier I can feel my feet, the stronger I feel, right?
Mhm.
And it's something I tend to notice with people that are getting stronger, but also just might not have a lot of mass to them. And they tend to not be as strong early on because they can't put as much weight through the ground. And if I cue them to say, like, feel your feet, they don't know what I'm talking about, type of thing. Well, that makes sense, right? Like, there's not as much mass going through the ground, but that also makes it harder to lift more weight. And that's why you see heavier people can lift more weight. There's weight classes and things like that. But you had made a relationship for me of my left heel is similar to my back molars in contact, right? And that idea there, from a practical standpoint, to me is like all of those things you just said about different muscles. Like that was my cue. That was like, oh, that makes a ton of sense, right? And then it's now become this way of looking at, like, if my neck is a little stiff, it's like, let me just like put my back molars together. Let me feel my like left sit bone a little heavier if I'm sitting,
Yeah,
and like I can move my neck more. But it also helps me appreciate, like, if I'm being mindless at any moment, just doing a bunch of Zoom sessions, doing a lot of writing and sitting, that my body is going to drift in different ways. I have these references now that will have an effect on a lot of different musculature, that the more specialized you get, you can actually name the muscles, which is cool. But like you can also then backtrack to the more practical, like feeling, the proprioception, as you said, of you're connecting the dots to anatomy, but you're also connecting the dots to pressure and feeling. Is okay, I can feel heavier in my left pocket. well, now I also feel my teeth come together. Or you can use like a tongue depressor like we've done, where just you hold that down on the left side. Well, now can your neck move a little bit better? That becomes actionable, where it's like you could actually do that while you're training sometimes and see, do you feel stronger on your overhead press? Do you feel like stronger on your deadlift? So because of the work we've done together, because of some of the works at PRI, like I just mess with that stuff now, and it does help. Like my breathing for high intensity pressing used to be strong hissing, bite down. Now I tend to, if I'm in this place where it's not like an absolute max effort, a lot of it is tongue pressure to the roof of the mouth, because I feel like it keeps my airway open more. I don't need to breathe through my mouth nearly as much. Like I was doing that because I thought I should, but then I realized that's a waste of energy, and now I'm able to divert the energy into better places. Those are, to me, like all of the places where even if you aren't working with a dentist, you can actually get actionable benefit right away. But what you tend to need is that initial assessment. And there's probably going to be some general patterns that you see in a lot of people, but there's also some specifics that you need to know, like what is the cue for you? You might have to have a slightly different cue if you're sitting versus standing, if side lying and all that. But it fits with those iterations, or the those kind of relationships through the body that you're talking about. And they're so obvious once they're pointed out to you.
Yeah, no, you're absolutely right. And, like you said earlier, really all of this is we need more to happen with you doing less.
Mm-hmm.
And, it shouldn't be so much work. And when it starts to become so much work to keep yourself together, we got to zoom out and say, how can we give the brain more options on the menu for how to recognize where it is in space and move freely? So when we do this work, it's really just to make life easier, to kind of tee them up for success. Some of the main things that are big recommendations for someone, right? Or at least ways we would say, all right, this is relevant, is even for anybody listening right now, like we would want to see when your teeth come together, where do they come together? When your teeth just come together, you should be able to feel your back teeth touching evenly at rest.
Hmm.
And you should then also be able to move your jaw to one side and feel teeth on just that side touching without the other side touching. And then you should be able to move to the other side and feel just that side touching without the other side also coming with it. That's a very simple base thing. There's also specifically other teeth we would really want you touch in certain ways. Where those teeth end up oftentimes are a reflection of what's happening in the cranial bones that they attach to, the maxilla, the palatine bone that's behind it, and even, the temporal bones up in here, as well as the head and neck. So it doesn't automatically mean that we got to run you to the dentist right now, Chris. If that's something that is a persistent thing for someone, or sometimes if they can't feel one side by itself without the other side coming with it, or if I say, hey, can you move your jaw to the right? And they move it to the left. And I say, no, the right. And they move it to the left again. And they go, I'm doing it. And I go, no, you're not. Right?
Yeah.
If they that lack of awareness of where that jaw is, and it correlates with other tests that we would do, it starts to get me to understand this person's jaw is not getting these lateral trusive movements that would help give their brain a good sense of right and left.
Like, are you familiar with the NOI group out of Australia that does like graded motor imagery? And
I've heard of it. I don't know a lot about it.
So, I mean, they have it broken down into like 3 categories, but one of them is left-right discrimination. And it's just like connecting to what you're talking about. I think it's fascinating because they have like an app called the Recognize app, where you can actually see different images, left versus right. And then they're looking at accuracy and speed for how good you are at them. And then there's like different levels, like a video game where it's, very obvious right side up view of a human being. And then it can be like abstract art flipped around. And if you're still able to figure out left versus right, it's a higher level task. And their thought process there is like they're specific with persistent pain, that it's almost like pre-movement assessment of pain. So if it's difficult, there tends to be an association to people being in more pain. And if you can improve it, it's trainable, then it can actually be part of the damping down of pain. They don't really mention like any of the connection to maybe some of the specific anatomy or some of the specific like proprioceptive ligaments and things like that that might be involved. So there might be a connection there that's kind of interesting, but there's certainly evidence that shows left versus right discrimination. If that is negatively affected, it can actually promote more persistent pain over time.
Well, I can certainly understand that. Part of my stuff, and as I went through some of the vision stuff, maybe we'll talk about another time. There was exercises where there was a lot of right-left stuff and with mirrors and all that, and it was challenging at first. And I could certainly see the value in that. The proprioception to the brain is and how certain teeth touch. Like for instance, I have a patient who came to me and he was on the Parkinson's spectrum of diagnoses and disorders, and he had gotten medicated to the point where he started to develop this pretty significant dyskinesia kind of tremor. And he came to me, it was I think in like I want to say like a January or February situation, and as we went through his history, it came out that his symptoms all got a lot worse after he had a molar removed. It was actually on his left side, like a few months prior to him. But even some of our tests early on, if we put something back in that area and he could feel a little bit more, whether it was gum or a popsicle stick, and he could feel certain teeth back there touching with the top ones that he still had, even though he didn't have the one tooth. We were just optimizing proprioception in his molar region. His dyskinesia started to kind of calm down, right? So one of the cool things was on the night that we delivered his splint, meaning the day it came back from the lab, where we were all meeting up, me, him, and the dentist to put it in. He was having a really rough day, and he came in and he was really shaking really bad. And when we delivered it, he's laying on the table and his left leg was trembling so bad that I literally had to hold it down with like all my strength to try to really just get him in a position where we could really get this thing in his mouth. He put it in, and as soon as his brain picked up that feedback was there, that area of his body existed, his body relaxed. Wow. And he was able to stand up and walk down the hall like you would never have known, right? But when I see things like that, I can't unsee that and think about how relevant this stuff is for everybody. Whether we're talking about somebody who's in that kind of a debilitated condition, or even just some of maybe my athletes who are just trying to get like 1% better, know, and because that's the difference in getting their next contract.
Yeah.
So I can't almost look at anybody for whatever they're dealing with and start wondering about, okay, how's their body organizing itself around these important reference centers? And how is their body organizing the sensory information to understand where they are in space? What things are not on the menu of options in their brain's map of what sensory stuff exists, and how it's going to come up with a plan to walk from here to their car? And how do we give them in the most efficient way the most amount of options on the menu for movement and for stability?
Yeah, I think we used that terminology last time, like options for movement, for general like function of your physiology. And I think that's the key. The interventions that have to be done by like another professional that might be like more along the lines of surgery, bracing. And I just think of even that is within a spectrum. And when you can be with the person that is more process oriented, like a physical therapist, we're more process oriented. We're making adjustments, we're testing, we're retesting, we're trying to connect dots throughout the whole body. And then you have the professional that can actually go inside the body and maybe make a structural change. If those two professionals can be working together, then that spectrum from process oriented healthcare to intervention specific or surgical based healthcare, they work together. Even when you have a relationship with surgeons, it's really hard to have the two worlds work together. And then they almost become like polar opposites in the head of the patient, where it's like surgery is this thing that it's a cure, it's a fix. No, it's part of the process for giving you more options, right? Like if you get a surgical intervention, whatever it is, you're not fixed. You're not back to what you were. You're different. Different might be better, but different is not the same as what you were. And I think that's just an important thing to discuss, where how much do you want to go that route with things being a little bit more invasive?
Mhm.
If you're there with the person that's also helping you with the process oriented things that can be worked on your own, and still will need to continue to be worked on in some way, even if you give yourself more options surgically, that allows the intervention that you're doing, that you're maybe investing in, that's a little bit more invasive, to be less risky, but also to be more effective, because we don't separate it out where it's like, okay, I'm just going to decide to do surgery, or I'm throwing out everything else I've learned from the therapists that I worked with, from the people that like taught me a little bit more about my body. That didn't work. I'm going to do the surgery. No, it's not that. It's that both of them are in a spectrum together. And I think what you're doing is awesome. And I wish more of healthcare was that way, where we were in the same room with people that just offered different interventions, so that it didn't always look like you were making a decision like, am I going to go with this intervention or am I going to go with that, instead of how do they work together. And so I think like what you're describing there is, to me, what like would be more optimal. And even like if you do all of your assessment and you're like, yeah, they really could use it. Sometimes like you could just be so diligent with the process oriented stuff, right? Like with whatever you're doing from an exercise standpoint, from a mindfulness standpoint, from breath work, that you get so good at that, you make yourself in like the best condition of your life. You change your sleeping habits, right? Like there's so many things, so many boxes you can check on that process side that can actually start to help.
Mhm.
But again, if you might give yourself an easier time if you then make the structural change, that to me is the best of both worlds. If it doesn't have to be such a big investment to try those things, right?
Yeah.
And right now, I think in a lot of ways it is like to have a surgical attempt at something, or some type of, orthotic attempt. It's like, I got to go and totally see a different person. I got to, pay for it out of pocket. If it's well integrated into the practice, then it makes all of that easier. So, and I think like what you're doing is pretty like revolutionary there. And I hope it continues.
Well, thank you. I mean, I've really been blessed to, at this point, really have some really good other practitioners on my team where we can have these conversations, and they're open to having the feedback of where it's what's the state of the person's body.
Mm-hmm.
And it took a while to find these practitioners and to build the relationship with them. It's a journey I've been, working on for over 10 years now, but I feel really good about the team I have in place, and I'm fortunate for that. In the dental, even in just specifically to your point, in the dental field aspect of it, I'm going to be clear. There's nothing wrong with orthodontics and braces. My experience is that I just have to be careful about what person we're straightening those teeth on.
Right.
So a lot of times with this dental integration piece, if we're going to get a splint for somebody, it's almost like pre-dentistry. It's like
Right.
pre-orthodontics. It's like we
Right.
want to make sure that if we're going to straighten these teeth, which you probably need to, but in the meantime, we're going to give you perfect bite, but with an optimal head and neck position while your body learns how to find better balance.
Mhm.
And then when you can hold it and maintain it, that's when we can put braces on. But we
Right.
don't want to put braces on a twisted system. So,
Yeah.
but some people get to the point with the splint where they're like, yeah, look, technically I know I need braces, but as long as I wear this splint to sleep in and to work out in,
Mm-hmm.
pretty good. And like, okay,
Yeah.
that's great. That's great when that happens. And
Yeah.
I was in braces when I was in my 30s, but it was only after I had done the pre-dentistry piece. And if I had done braces in the beginning of it, before I went through the splint and then that, and even a little expansion, would have just locked me up more.
Mm-hmm.
So we have to consider the canvas and the person and the
Yeah.
state of them if we're going to be doing things that are hard to kind of undo. And I think you're absolutely right. And whether it's me and a dentist, or even other practitioners, having the team together, and people being able to basically report out on their department, because we now know how much all of these departments are interconnected,
Yeah.
is really key.
Yeah, I like that you say like pre-dental, because then you could think of just any type of dynamic bracing where you could put it in or you could take it out. That
Mhm.
just would be like earlier in the spectrum of process to surgery, right? So like then there is stuff that somebody is doing from an exercise standpoint that they're not actually trying to put something in to hold a structure in a different place, but we're using fitness, we're using other types of methods that are a little bit more dynamic. And then as we start to move more towards one side of the spectrum, towards surgery, we would do some type of splinting that is more dynamic. And that could be orthotics, which you alluded to. But the more specific we can get with those, the better. And then I think you have to have the education piece too. So what I've seen, and I'm sure you've seen this over the years when it comes to orthotics, is that there is this mentality that's like, okay, I figured out what I need. I need this orthotic and I need it all the time. And that's it. End of story. And so if you have some type of dynamic bracing or dynamic splinting system, there also has to be an education of how do I assess when this is useful and how do I assess when it's not so useful and not so necessary. And I think that conversation happens in so many ways around footwear. And I'm sure like anywhere else in the body where it's like, oh, this worked in this moment, so now I'm just going to wear it all the time. And then your body almost gets used to that. And now it can't be without that. It's a general dependency. So that's just something to be aware of. And I think that's an important step before making a surgical decision, because if you do get something that is more permanent in your body, now you can't assess that anymore. It's in there for good. It could be very good at first, but things change over time, right? And the body is meant to be dynamic. You know, I certainly have gotten used to the idea of like different footwear for different function, right? Like I love being barefoot, but I remember making the mistake of trying to go rock climbing barefoot the one time or with my Vibram 5 fingers. And I'm like, not for this task. Right? And then you learn that, right? And then running shoes might be different than walking shoes. You know, it's like we appreciate that. And I think the same thing could be said with orthotics or some type of dynamic bracing. Is there might be a point in time too when symptoms are really high. I want to use that more. But then when symptoms are coming down, I might want to use that less. I love using weight belts in the gym because it shows people that they can do more than they think. But I don't want them walking out with my weight belt and wearing it all day, right? But it shows them they can do more in that task, in that moment. But if you get a surgical weight belt put on you, now you can't go back, right? Like that's a very different thing. So I think that's an important discussion there. And the splinting is very different than bracing. And sometimes, you know, bracing for an extended amount of time is that next piece in the spectrum, which could be quite useful.
We do a splint with somebody. I always have to make it very clear early on that, look, this is a process, not one piece of plastic that cures all your problems.
Right.
So,
love it.
Because what we're doing, if we're identifying that this is going to be helpful for you, it's because there's some issues with your body that we need to change.
Right.
But we just are having a tough time with your teeth touching the way that they currently are. So when we put this thing in, it gives us a window of opportunity to then turn on the things that we couldn't, or to let go of the things that we couldn't prior to it, as we get your body in better balance. And it has to be matched to a program where we're giving them exercises to do now that we have this window of opportunity to create normal and to create more more options on the menu.
Right.
But as they do that and make changes in their body, they're going to start touching the splint differently. So then we're going to have to periodically meet up with the dentist again to get him to shave down that splint in all the right places, to get the splint to catch up to the new new patient, right? And we want that splint to be down to almost next to nothing. And then maybe you get to the point where you're like, you know what, I feel great as long as I wear this, fine. Or maybe it's then, okay, now you would be a good candidate, you know, for braces. But yeah, we certainly want to not use the splint any more than we have to. And we want to optimize the window of time where you're wearing it to be able to rewire the nervous system and get the body the access to the things that we've identified it needs now that it has access to those things.
Absolutely. And I'll give a plug to you. Some of this stuff up in the head, in my practice of it as a therapist, it's hard to feel. And this is something I've learned over the years, is that it doesn't mean it's impossible to feel. It means it takes a lot of time to get good at this assessment. But as your hands get better with things that you do more often, it becomes more obvious to your hands. So it speaks to the idea of proprioception. Well, we can get more proprioception in our fingers. And I think it becomes more obvious. Like I know I felt that with different joints over the years, just to feel things that I was told to feel when I was in school, but I didn't have the experience in my hands yet to make any sense of it. I know what I'm not going to be good at assessing, and I know what other people are going to be better at assessing. And I think there is a mentality that if somebody doesn't have that awareness of how to use their hands, how to feel things with their hands, how to feel range of motion in the neck, in the jaw, the TMJ, then it's like, oh, that doesn't exist. They're making it up. No, it's just like they have this feeling in your hands, and it's like any other skill, like any other motor skill that you've gotten better with over time, right? Like you don't have to think about what you feel. Like when you get better at golf, you don't have to think about your grip as much as you did when you first started. I would refer out to people like you for this assessment, which you're going to have to look at and it's a dynamic assessment that you're looking at while someone's going through the process of possibly splinting, but that you're coming back to how does that feel from a neutrality standpoint? Mm-hmm. You want somebody who's really good at that to be able to assess that for you. And then I think, like we've talked about many times, is you also want to have a process outside of that too. That is like, okay, what are the things that are you really care about from a functional standpoint? Is it running? Is it weightlifting? Is it just walking, sitting, and not being in pain? But you kind of want to have a process there that you're assessing change with. With this kind of stuff, you do really need someone with a specialized hand because it's small anatomy. So you have to be able to feel things in a very expert way. And I would say, like, I would recommend you much more than I'd recommend me for that kind of stuff. And then there are people that like you just want to know what their specialty is because nothing can take the place of experience with your hands with this kind of assessment.
Well, I appreciate that. Yeah, certainly something that, it has taken time to learn and get better and better at, and is something that, I'm always trying to continue to perfect. And, sometimes, I'll have some work done on me and I'll be so impressed, like, oh man, like I like, like a good, really good osteopath that can on you and get deep down into certain things. Like, I'm like, man, I got to up my game even more, so it's always a process, but I appreciate the kind words.
Absolutely. We all appreciate you. This is a good discussion. Hopefully there's some actionable things that came out of this. I'd like to do more of these where we kind of look at different areas of the body. So today we talked mostly about dentation, the airway piece. Maybe we can talk about things like vision. I know you do some work there, and then just going down the body and how we can look at these iterations like we talked about, like we got the cranium and we got the TMJ. But then we already alluded to, in the rib cage, you got the sternum and that rib cage relationship. There's a lot of interesting relationships there that are super practical. Like once you talk about and they connect to things like shoulder health, to neck health, to lower back health, to even just like breath work. Obviously, that's where, like the area of where the diaphragm is. But then how, if we talk about the pelvis, we might be having a similar conversation just in a slightly different way. So that's my hope with these series of podcasts, that we get into the weeds a little bit, but we try to make it practical as much as we can. And how do we like think about that when we're doing stuff that we're doing all the time anyway? Yeah. But then why would you need that specialist who's just got that experience and can see things in a way that we wouldn't expect someone who doesn't have that education to see?
Yeah, that sounds great. I'd love that. Thank you.
All right. Awesome. Thanks, Frank.
You got it. Thank you, Chris.